Hello everyone. In this video, I am going to be covering some movement analysis, but more from the standpoint of how I use movement analysis to help with my differential diagnosis, and then also to help with patient education and treatment purposes. Specifically with this case, I will be talking about an individual who came in with right shoulder pain, approximately in his late 50s, and then aside from pain, he was actually complaining more of muscle weakness in the pectoralis muscle, and then he had noticed a gradual decline in his right bicep strength over the past few months. So here is the video. And then right away, you can see as he's activating the muscle, there's a portion of the pec that appears to not be firing. I'm going to play it again here in a second. And I want you to see at the top of the video, or towards the top of the contraction here, the muscle starts to quiver as it gets into that shortened position. Oftentimes, clients have questions why muscles go into a state of spasm or a state of quivering. It can be because the muscle is not strong enough. It may not be getting enough innervation. Or when it gets put in that shortened position, there's not muscles to counterbalance it. So when a muscle is in a shortened position, it might go into a state of spasm or overcontraction because it doesn't really know what to do in that situation. If it's placed in a situation where it has to fulfill multiple roles to act as both a mobilizer and a stabilizer, such the hamstrings is a great example of that too. It can go into that state of quick contraction and spasm, that involuntary contraction. So to quickly review the pectoralis major, the origin, and this post, I'm going to be talking more about those sternal fibers. So as you saw in the video, the upper portion of the muscle really was not firing, and that's those sternocostal fibers. And knowing this anatomy here is going to be key for the differential diagnosis that we talk about next. So the origin is going to be the anterior surface of the sternum and the upper 6 costal cartilage spaces. It inserts onto the humerus, and that's why it gives you that horizontal adduction and also medial rotation of the humerus. So that action of pulling across here is really part of the sternocostal fibers of the pectoralis major. The innervation is the medial and lateral pectoral nerves, and that's going to come from C5 or C5-6 to T1 for both of those. But then when we specifically talk about the sternocostal fibers, that is more of our lateral pectoral nerve of C5 to C7. As you can see in the picture, the darker red on the top is the sternocostal fibers. Below we have our clavicular fibers. And then on the left side of the picture is, you can see the pec muscles and then also some of our muscles of inspiration. I do want to note, which it wasn't pertinent for this case, but some individuals with pec muscle strains will complain of some difficulty with deep inspiration or a forced inspiration. And that's because the pec muscle has a secondary action to help with that forced inspiration to get that really deep breath. When we talk about differential diagnosis, there's going to be several things that I like to think about, all of the potential structures that could be in the area or that refer to that area. So right away, this could be a pec muscle strain with resulting just atrophy of that muscle over time. Now, because this individual had some weakness in his bicep also, and then he also had weakness, some posterior scapular weakness that he actually didn't know about, but that was something, just because he couldn't see it, he didn't know about it. But that was something I noted on the physical exam also. So for me personally, I was not thinking just a pectoralis muscle strain. When someone comes in with a muscle strain, likely they're going to have a resulting some sort of mechanism of injury. And while this gentleman actually had some sort of bike injury a few weeks earlier, he doesn't really recall hitting his shoulder directly, and specifically does not remember any bruising, swelling, or redness in that area that would indicate a muscle strain. So if it's not muscle, other things that can then refer to that area would be the nervous system. So when I'm thinking about where it's coming from with the nervous system, Is it going to be centrally, like cervical myelopathy? Will it be more radiculopathy, which would be a nerve root problem? Or is it going to be more of like a brachial plexus or a peripheral nerve type injury? And all of those are possibilities in this case. So we need to tease out which one it is. For a somewhere C5 to C7 nerve root dysfunction, well, with this, I am going to expect some muscle weakness and wasting. I'm going to expect likely some sensory dermatomal issues. He may have decreased reflexes of the brachioradialis, biceps, or triceps even. And then uh, differentiating that from more of a lateral pectoral nerve, so just entrapment of the peripheral nerve, then that individual would only have the pec muscle weakness. So as I mentioned earlier, he had multiple muscles that were weak. And although he didn't have any dermatomal issues, he was still, since it was multiple muscle groups, we have to start thinking beyond just a peripheral nerve problem. The last one down there is thoracic outlet syndrome, and that really is kind of a catch-all diagnosis. I put that on there because you're going to see that on scripts from physicians, but that kind of cues you in that somewhere in the thoracic outlet region is the problem. And really, any of those, well, those two more nerve-related ones, could be the the real reason behind the diagnosis of thoracic outlet syndrome. And if it's neurogenic thoracic outlet, it often does well with conservative treatment. Now, if it's vascular or arterial, which this gentleman did not have, then he would need to be referred out. Going back to the nerve issues, the reason I determined that he had more of a cervical spine issue here was the fact that other muscle groups from that C5-6 area were also impacted. So his teres muscle groups were atrophied, his subscapularis and infraspinatus muscle had atrophied, and then he had noticed weakness in the bicep. So he had decreased activity in the bicep muscle. For this individual, it was my recommendation that he go see an orthopedic specialist or go back to his primary care doctor so that an MRI could be ordered, because I really thought that he had more of a cervical spine issue. Upon getting the MRI, he actually was found to have moderate to severe cervical myelopathy type symptoms or central cord compression at levels C5-6 and C6-7. And his neurosurgeon at that point recommended that he have a spinal fusion. Now, this individual is still determining what he wants to do. He's not having any pain at the moment, but because of the muscle wasting, the gradual weakness of the pecs and the biceps and the posterior shoulder muscles, he will likely need some sort of cervical fusion surgery in the near future. Now, it's not adamant that he gets it right away, but he needs to be careful with other high level activities that he's doing to make sure he doesn't fall and hit his head too abruptly. And then also he needs to monitor that muscle weakness and then assess for any other signs of cervical myelopathy. So I found this to be an interesting case because he came in with pec muscle weakness and some shoulder pain, but the true cause was really more of that cervical cord compression and then also some lateral or foraminal cord compression. So thanks for listening, and please reach out if you have any questions. Thanks.